Thank you very much. First of all, can everybody hear me?
Yes, thank you.
Good. And Marco's asked me to give a message before I start. Could anybody that's filled in his forms please leave them on the table in front of Marco at some point this morning? I'd secondly like to thank Paul and Tom for inviting me today. And I'm, like our visitors from down under, I'm awed by how many people there are here that have survived a cardiac arrest. Now, although I've worked in brain injury rehab for 42 years, very few survivors of cardiac arrest get referred to us. We see anybody with non-progressive brain injury of whatever diagnosis, and there are really very few people with cardiac arrest that come through to us. Now, it says on the programme I'm talking about memory, and I am going to touch on memory, but I'm also going to talk about other cognitive problems resulting from anoxic or hypoxic brain damage. So the brain requires a constant supply of oxygen to function properly, and deprivation of oxygen can result in permanent brain damage. Now, if that occurs during birth, the survivors will probably be referred to services dealing with developmental problems and learning disability. So we won't be talking about those today. Here we're concerned with those who've hypoxia or anoxia, which happens after the perinatal period. Now, anything with an A in front, anoxia, apraxia, amnesia, means absence of. And anything with a hype in front, HY, means reduction of. So hypoxia means you've got low oxygen or reduction of oxygen, and anoxia means you're completely deprived of oxygen for a period. But in fact, people use those two terms interchangeably. And the main causes of hypoxic brain damage are cardiac and pulmonary arrests, which most people here have had, embolism, so a blood clot in somewhere in the body that goes travelling up, attempted suicide, particularly with carbon monoxide poisoning. These are the people I see that have attempted suicide through carbon monoxide in their car, and they get resuscitated and then they get referred to me. Drug overdoses, hanging, near drowning, anaesthetic accidents. There's lots of causes for this shortage of oxygen to the brain. But the one we're concerned with here is those who've got shortage of oxygen to the brain caused by a cardiac arrest. Now, one of the books I've done 30 books altogether, but one of them that came out in 2014 with two colleagues, Jill Weingartner and Fiona Ashworth, is about 17 survivors of non-progressive brain injury. Their brain injury was from a number of causes, and each chapter in the book is written partly by the survivor and partly by the neuropsychologist. But one chapter in the book is written by a survivor of cardiac arrest, a young man I know well. But in the book you can certainly read what the patients themselves think of rehabilitation. But this is the young man. He was from Bogota in Colombia, South America. He was having a a knee operation, and he went into cardiac arrest. And he was referred to us by his neuropsychologist, who's in the middle there, Patricia Montanes, and we didn't want to take him because ours is a British centre, and we like to, part of our programme is reintegrating people back to where they live. But it was the lesser of two evils, so Jose came to us. He actually did extremely well. He's now working for the Colombian government. He was studying medicine. He didn't go back to medicine, but he's working as a health researcher, and he's employed by the Colombian government. So he's done very well after his cardiac arrest. But the problems these people, anybody with hypoxic brain damage might have, they don't have all of these, but these are the ones they might have, certainly motor or physical problems, sensory problems to do with vision or touch, less so with hearing because of the way the brain's wired up for hearing, but certainly problems with vision and touch. Cognitive problems, the ones I'm particularly concerned with. Behavioural problems, social social difficulties, they lose their friends go off to university or something and they get left behind. Emotional problems, which many of the clinical psychologists here will be dealing with. Problems with pain, problems with fatigue that we'll hear from Donna after me, and so on. And the cognitive problems, whether they're problems with memory, common, problems with attention and concentration, with communication, with planning and organisation, with reasoning, with perception, spatial awareness, and so forth. It depends which part of the brain's been affected. Now, memory is common because the hippocampal areas crucially involved in memory are very dependent on oxygen. So any oxygen deprivation is likely to lead to memory problems. But there's one of the perceptual difficulties that you only ever see after severe hypoxic damage. That's called Balint syndrome, which you probably won't have heard of, but people can't localise in space. They go to reach for something and they misreach. And I've seen a few, it's a very rare condition, I've seen a few of them, and it's almost always caused by shortage of oxygen to the brain. The emotional and psychosocial problems we see are anxiety, depression, anger, fear, distress, grief, poor self-esteem, lack of confidence, and so forth. And the kind of behavioural problems that we are faced with in rehab are temper outbursts, shouting, swearing, physical aggression and verbal aggression, disinhibition, poor self-control, refusal to cooperate, etc. And all of these should be addressed in rehab. If you're getting a good rehab service, people should be addressing the cognitive, emotional, psychosocial, behavioural problems. Okay, so now I'm going to touch on memory. A simple definition of memory is the ability to take in, store and retrieve information. That's a simple definition. It makes sense to patients, clients, survivors, makes sense to their families. And there are basically three main types of strategies to help people with memory, help them manage in everyday life. One way is to help them learn more efficiently. One is to help them compensate for their difficulties. And one is to adjust the physical or verbal environment to avoid the need for memory. These aren't mutually exclusive. People use all three of those for different problems. Let's just have a look at some of those. So, helping people learn more efficiently. Some people think it's just a question of repetition. It's widely used, but by itself, it's not sufficient. Goes in one ear and out the other. Repetition on its own is not the answer to helping people learn more efficiently. These are some of the methods that do work. Spaced retrieval, also known as expanded rehearsal. They're synonymous terms, they mean the same thing. Where, I'm not sure if I'm giving you an example of that or not, but I might be. And the third way, errorless learning, or avoid trial and error learning. And finally, vanishing cues. So I'm going to tell you what each of those means, each of these last three. Spaced retrieval, or expanded rehearsal, you test the person, you give the person the information they need to remember. It's typically a new name or a short telephone number or an address, something short, something in their immediate memory, which is usually unaffected. And you give them this information and you test them immediately. You say 249670, whatever the telephone number is, and they can do that back, because that's the part of the memory system that's not affected, usually. Then you test, so you're testing immediately, then you wait a second or two, a very short delay, test them again, then you gradually increase the delay. Now they've only heard the information once, but you're gradually increasing that test interval. You're spacing the retrieval or expanding the rehearsal. So you're gradually building up this retention interval, and you can teach even severely amnesic people a few pieces of useful information doing it this way. All this is backed up by research, and if you need the references for that, you just email me. Now, errorless learning has become very important in memory rehab. It's a teaching technique whereby people are prevented, as far as possible, from making mistakes while they're learning a new skill or new information. And you can carry that out in a number of ways. It's a principle rather than a recipe. You can provide spoken or written instructions. You can guide somebody through a task. But what you're trying to do is avoid mistakes being made during learning and to minimise the possibility of incorrect, erroneous responses. Now, we started doing research into this in 1994, but it's been used regularly since then. So errorless learning has been used to teach several everyday tasks to people from different diagnostic groups: cardiac arrest, TBI, schizophrenia, Alzheimer's disease, of different ages and at different times post-insult. It's a very robust principle. And errorless learning has proved to be superior to trial and error learning for people with severe memory problems. I could talk to you about other problems, but we'll stick to memory for now. Now, another way of improving learning is the method of vanishing cues, whereby prompts are provided and then gradually faded out. Started by Elizabeth Glisky, recently retired but still alive, a friend of mine. So let's suppose we're teaching a guy the name Caroline. This was actually one of our patients. He copies it first, then we leave off the last letter. He copies it and completes the last letter. Then he completes the last 2 letters, the last 3, and so on. It was first reported by Glisky et al. In 1986, and a number of studies since then have reported some success. Now, I'm not going to be talking about compensation because I'm not doing the whole talk on memory, but compensation and adjusting the environment are 2 other important principles. Now, another thing that frequently happens after anoxic or hypoxic brain damage is the dysexecutive syndrome. Used to be called frontal lobe syndrome. Now, the term was coined by Alan Baddeley in 1986. To describe the nature of the impairment arising from frontal lobe damage. He thought we shouldn't call a problem after an area of the brain. We should give it some other name. And then in 1988, Alan Baddeley and I wrote a paper about it based on some earlier work from the 1930s. So the dysexecutive syndrome is impairments in attention, so you're easily distracted, difficulty grasping the whole of a complicated state of affairs, but you may be able to work along routine lines where you don't have to think on your feet, and they have difficulties, these people, in new situations. Certainly a lot of the work we do at the Oliver Zangwill Centre is focused on helping people with the dysexecutive syndrome or executive difficulties. Now, the potential emotional and behavioural consequences of these frontal lobe lesions, emotionally, they can either be very flat and apathetic, or they can have this lability where they're changing rapidly from crying and laughing to, from crying to laughing, typically. Behaviourally, they may have adynamia, so they're not doing very much, they're very flat. And they don't initiate things. You may see impulsivity, utilisation behaviour, also called environmental dependency syndrome. This is where people respond to something in the environment inappropriately. So if they see your comb in the bag, they may pick up the comb and comb their hair, even though it's yours and they're not supposed to be doing that. And I've said, tell about M. That was a patient of ours recently. Every time he came through the door, he would see an umbrella in the corner, waiting there in case it was pouring with rain, and he'd pick up the umbrella and open it. Completely inappropriate thing to do. That's utilisation or environmental dependency syndrome behaviour. And they may be very disinhibited. The potential cognitive consequences of this frontal lobe damage are, well, planning, organisation and strategy application difficulties. They have problem-solving difficulties, reasoning problems and difficulty making decisions, problems with sequencing things, and informing and shifting concepts. Or they have difficulty with the changing their mental set. They have problems using feedback, and they may perseverate. And I thought I'd just show you, and problems with fluency, yes. This was one of the patients of a colleague of mine, asked to draw a clock. She had frontal lobe damage. Now, the clock's not wonderful, but it's not too bad. It's not like a neglect person's clock. Then she's asked to draw a house. We get the clock again. And then she's asked to draw a person. And we get a person, but with a clock face. Now, that is extreme. You don't see that very often, but that is an example of perseveration. You're more likely to see it where a guy's shaving at the sink, keeps shaving and shaving and shaving, or they clean their teeth for an hour when they're supposed to be doing it for 2 minutes, that kind of thing. And the potential emotional and behavioural consequences, we've already said that, haven't we? Am I going the wrong way? Have I put it up twice? Yes. Sorry, so that's all I was going to say for the moment about dysexecutive syndrome. And I just wanted to quickly touch on perception, because these are some of the people I see after they've had this hypoxic brain damage. Perception is the process of integrating information we receive from our senses. So it's not actually seeing, it's making sense of what you see. So making sense of what you see or hear or touch or taste. But I'm particularly concerned with the visual perceptual difficulties. Adequate sensory functioning is necessary for normal perception, but impairment at the sensory level can't be described as a perceptual problem. So if somebody's blind and can't see, you can't say they have a perceptual difficulties. They're two different things. One's to do with acuity or eyesight, and one's to do with the brain making sense of this information. Now, one of the problems that you sometimes see is this difficulty recognising things from an unusual angle. 5 minutes left, yeah, okay. So now if I asked you what this was, some people might say a magnifying glass, and especially if you're older. And if I said, what is this? They might say it's a wheel. But if you show them the same object from a normal angle, they get it right. So that's not a magnifying glass, it's a saucepan. That's not a wheel, it's a bucket. So these people are not agnosic, they recognise the object from a normal angle, it's they have problems from an unusual angle. And they're the kind of people that typically have lots of accidents and so forth. But you sometimes see agnosia caused by hypoxia. That's an inability to recognise. So it's visual object agnosia. There are lots of different agnosias. There's agnosia for topographical agnosia, people can't find their way around. Agnosia for letters or word blindness. Auditory agnosia or word deafness. Colour agnosia. And simultan agnosia, which is where you can't see two things at the same time. So these people might not be able to read because they can see individual letters, but they can't see letters that are side by side. And that up there, an iron, one of my agnosic patients said it was a shoe. Now, you would never get that kind of error from somebody with, sorry, with a language disorder or a naming disorder. They might go, it's a thingamy, thanks, or they might go, it's a thingamy, or they might give it a semantic error, like wash to do with washing. But they would not say it's a shoe. A shoe is a visual error. And you see that with people with visual object agnosia, but not with people with a naming disorder. So it's not whether somebody fails the test or not that's always important, and Donna and I were talking about this in the car this morning. It's how they fail. And the nature of the errors might be very different from somebody with a language disorder than with a visual object agnosia. Like, well, this is another kind of agnosia. One of my patients said this was a toilet. Now, a toilet? I thought, a toilet? And I think she's seeing this as the toilet bowl. She had an even rarer kind of agnosia, apperceptive agnosia, where they see things piecemeal. They only see a bit of the object at the time. And I showed it to her again. I said, tell me what you can see. And she said, well, there's a long bit that might be a handle. And each time I show her, she's giving me a different bit. And this, she meant to say thimble, she said, oh, it's white and bumpy, it must be a cauliflower. So you're looking at the nature of the errors as well as whether they've passed or failed. And the same young woman, she said, this is a plate of peas. And I think she's seeing the boat as the plate and the net as the peas. And I must have looked surprised because she said, oh, no, it's not, she said. How silly, it's a plate of beans. Then you get face blindness or prosopagnosia. And this patient of mine who I've written about, and she's quite happy for me to show her, Claire, she couldn't recognise any face. She certainly couldn't see mine. She didn't know famous faces like Nelson Mandela. She didn't recognise her own face. She said to me, I wake up every morning with a stranger in my bed. And that was her really nice husband, who was as helpful and kind as anything. Then unilateral neglect, you typically see this more often after a stroke rather than a cardiac arrest, but it's where people are failing to report or respond or orient to one side of space. So I don't know if you can see that clock there, that's a typical clock drawing from a neglect patient. I think I might just quickly tell you about Milan Cathedral Square, because this is an important experiment done by Bisiak in Italy some years ago. Milan Cathedral Square would be known to everybody in Milan. He was seeing patients in hospital, had their eyes closed, and he said, imagine you're in the Cathedral Square, what would you be able to see? And they described everything on the right and ignored what was on the left, because they're standing in front of the cathedral then. So he thought maybe it's more memorable on that side. So he did the control experiment. He said, imagine now you're standing in front of the statue, looking at the cathedral. What would you be able to see? And they then described everything that was previously on the left but now on the right and ignored the other side. That led Bisiak to say neglect is a spatial attention problem and not a visual problem, because they had their eyes closed, they were imagining it. Anyway, that's a whole nother talk at some other time. That's a typical drawing of a cat, and why I like this drawing, this is a neglect patient, why I like this is it shows it's not a motor problem. She's drawn the cat's whiskers beautifully, it's a very nicely drawn cat, but ignoring the left-hand side. And the final bit I wanted to say is it's not always easy to distinguish between these difficulties. And this is going way back now, but 3 patients were referred to me, each by their physiotherapists, with fear, extreme fear. And as a psychologist, I'm expected to deal with it. Now, on the surface, they all look the same, but there are 3 very different reasons for their fear. It's usually considered to be an emotional problem, and sometimes it is. It's not always what it seems. So the first patient, Mary, she'd always been frightened of the hydrotherapy pool. She'd never learned to swim, and with her, I think it was an emotional problem. The second patient was referred for fear of walking alone and of fear of transferring, getting from her wheelchair to her bed or the bed to the toilet or whatever. Now, that turned out to be a cognitive problem with her. She'd lost the ability to judge depth and distance perception. And the third one, Paula, she was referred for fear of physiotherapy, and our physios were very kind people, but she'd had some inappropriate treatment prior to coming to us, and hers seemed to be like a behaviour problem. And they all needed very different treatments, of course. It was very different reasons for their fear. And let's just take this. example. These are two examples from a test called the graded naming test. Probably a difficult test, some of these, or some of the harder items. Now this one, they're meant to say, if they yashmak. If they don't know it, they say, I don't know it. But again, it's these errors, the nature of these errors. So one woman said, this is the woman that's called the iron a shoe. She said, oh, it's a man with a hard-headed riding hat. And a man I saw at the same time said, oh, it's one of those, he said, it's a thingamy, women in the Middle East wear it. And similarly, the same two people, oh, where did I go there? The same two people with the other one, the girl said it's a bandy-legged man in a riding jacket. And the man said, oh, it's thingamy, one of those. He said, oh, I don't know the name, but women wear it for exercise. Now, they're both failing those items, but for very different reasons. The young woman had a visual object agnosia, and the man had a naming difficulty. He obviously recognised it, but he had a naming difficulty. So that's the kind of thing that the neuropsychological assessment would be looking out for. Sorry, I have nearly finished. This is the simple block design for one of the tests that psychologists use all the time. Right, so the patient's given 4 blocks and has to do that. Now this one's failed it, and this one's failed it. Again, they both score 0, but for very different reasons. So this one is probably a parietal lobe orientation difficulty, and this one is a planning frontal lobe type problem. So you wouldn't diagnose from that, but it would give you ideas to test out. So has this man got this particular problem or this particular problem? And then you go and test that out. I'm not going to say about dyspraxia because I'm running out of time here. Yes, I'm going to end up. Now, these are my last 7 books, I think, and 3 in press at the moment. But this is the one I was mentioning with the cardiac arrest survivor who's done extremely well in it. We've got 2 patients in that book who've really exceeded our expectations. And one is the cardiac arrest guy, and one is another guy who had a traumatic brain injury. So with that, thank you very much for your attention.